So we will be examining the barriers and considerations for people from the LGBTQ plus communities regarding their reproductive options. The focus is on how can access to and equality of fertility treatment for LGBTQ plus people, families and communities be improved. Now, this is a huge topic as it covers diverse groups of people with different and specific needs. And I always, when I'm starting to prepare my introductions for these things, look back in the BioNews archive. I was somewhat overwhelmed because there are more than 500 articles relating to different elements of tonight's discussion. So I'd highly recommend, if you want to do more thinking about this area, that you make BioNews your starting point to think about some of these things. And I have to say, I didn't get very far with my homework because I got stuck on the women's health strategy. Remember that. So we are now more than 2.5 years from the introduction of the women's health strategy. And what has it delivered? Well, you may remember that the strategy promised patients who are part of a female same-sex couple that they would no longer have to demonstrate that they have a clinical need for fertility treatment by having to self-fund multiple rounds of artificial insemination. Sometimes people were having to fund as many as 12 at considerable personal expense. Has this happened? No. So, somewhat frustrated by the lack of progress at PET, we decided to launch our fertility policy tracker so that we could keep tabs on what was going on, not just for female same-sex couple, but for heterosexual couples, same-sex male couples, and single people. And so you can see there in for England what your integrated care board does and more likely than not does not offer. Um, and there'll be links into the chat about how you can look at that. Anyway, before I get on to my soapbox, which I fear I'm slightly stepping onto, I'm going to stop doing that because we have 7 magnificent panelists who I'm sure will each be giving impassioned presentations of their own. So tonight we are going to hear from 2 expert clinicians who have a vast amount of experience treating the LGBTQ plus community, and they'll be, I'm sure, sharing with us what good practice looks like. We have 2 people involved in the Fertility Justice Now campaign to improve state-funded access for the LGBTQ plus communities, who'll be telling you about their manifesto. We have someone from the trans community talking about their additional challenges and how education and activism can have an impact. We'll also be hearing from an academic who's an expert in this field, who has studied gay men's use of surrogacy, not just in the UK, but in the US, Spain, and Poland. And because family law and the Human Fertilization and Embryology Act have struggled to keep up with different family formations, we have a lawyer on the panel too. I'm very pleased now to hand over to this evening's first speaker, Carole Gilling-Smith. Carole is CEO and medical director and founder of the Agora, which provides fertility services in Sussex, and they have a clinic in Brighton, as well as other clinics. Carole is a consultant gynecologist and expert in fertility and reproductive medicine. And I was looking at the Agora website where it says we celebrate diversity and champion reproductive autonomy for all, and are proud to be a trusted partner for couples and individuals from all walks of life, including those from the LGBTQ plus community. Carole is a contributor to books, including the textbook of assisted reproductive techniques and contemporary ethical dilemmas in assisted reproduction.
Thank you very much for the introduction. I'm delighted and honoured to share this stage this evening with so many eminent speakers who've pushed forward the boundaries in helping change the fertility landscape for those from the LGBTQ plus community. I've always been passionate about delivering inclusive fertility care, and working in the UK LGBTQ plus capital of Brighton means we've developed a great deal of experience, which I'd like to share this evening. My brief is to spend the next 10 minutes sharing my experience by focusing on same-sex male couples looking to parent through surrogacy, and also, if I have time, to cover some of the issues around trans folk trying to preserve their fertility before starting cross hormones or having surgery. And I'll close with some take-home tips for clinics on how to provide a most inclusive environment. Now, surrogacy is a complex topic for patients and can be a minefield of information to navigate. In the last few years, we've seen a marked rise in the couples approaching us to proceed with surrogacy in the UK. And I feel that that's, a part of becoming more open and discussing routes to parenthood that's encouraged people to come forward and be surrogate carriers. As a clinician, education of my patients is key. And so I'm going to start with one of the many slides that I share with my patients to help them understand how they have choices along their pathway. And if you look at this slide, you see, like on this left-hand side, you'll see that I include trans folk in my symbolization, that provided you're providing sperm, it doesn't really matter. We call these people not dads, we call them providers of sperm, and they can choose which way they like to be called. For myself, my pronouns are she and her. I didn't introduce myself because I was introduced, but we respect pronouns, and that's a very important starting point. Now, as we go on through the slide, there are two main pathways to achieving parenthood through surrogacy. The first shown here is probably the one that we encounter most in the clinic, which is gestational surrogacy, when the intended parents, biological parents, father or mother, as the case may be, provide sperm. And it's quite common for us to need to freeze the sperm and quarantine it before it can be used in treatment. But it doesn't have to be that way. There's a second stage where embryos can be frozen before being used for treatment in a surrogate. So in this pathway, you require both an egg donor and a surrogate, and they're not the same person. So IVF is really the key to embryo creation. The donors are also screened in the same way as the intended parents, following very strict HFEA guidance, and the surrogate likewise. Now, when we choose what to freeze, you'll see that more complex conversations occur as we move into the screening requirements. So I'm going to come back to this point. So decision-making at this stage is around who is going to be the egg donor, who is going to be the surrogate. Do we freeze sperm first, or do we go into freezing embryos and quarantining those embryos? The second pathway is more commonly known as straight surrogacy, and here the surrogate also provides the eggs to create the baby. And in such a case, you have a choice in the treatment pathway of using intrauterine insemination of sperm provided by one or of the intended parents, or to go through IVF. And the choice is often determined by clinical needs. For example, if the sperm parameters are poor, we would encourage IVF or IVF with ICSI. And it's often the surrogate's preference not to do IVF. So, IUI or insemination of sperm would be their preferred choice. Now, if we look at the considerations for screening, it is a requirement by the HFEA that intended parents are screened as donors, and that also includes the egg provider, which will be usually the egg donor. And the conditions are listed here as HIV 1 and 2, hepatitis B and C, HDLV 1 and 2, gonorrhea, syphilis, chlamydia, and CMV. Screening must be done before providing the samples, which are then frozen, and then 3 months minimum after freezing. A genital examination is required in male partners. And the challenges we have are these. HIV has recently become a possibility. So those living with HIV who have an undetectable viral load can now be allowed to provide sperm as donors, which is really a positive move, and it's only a recent change in law. But hepatitis B and C positive intended parents would not be able to be used as the sperm providers in the surrogacy pathway. That law may change in the future, but currently you cannot. In past infection with syphilis, which we see quite often, and it's not a problem, we need to exclude active infection. So there are two parts to the syphilis test. One detects the antibodies to past infection, known as TTPA, But the key one is this test which detects active infection, RPR. And we often find that we see some active infection in somebody that's had a non-effective treatment or has only recently had treatment. And those levels need to be repeated before we are able to use the sperm in treatment. And this is something that some clinics are not aware of. And it's really, really important that we see RPR negative samples. And we need to see an evidence from a GU clinic that effective treatment, usually with penicillin, has been provided. And the third flag here is CMV, which is a bit of a flu-like virus, but it's tested for because if for any reason it is passed to the surrogate as part of the treatment process, it can cause conditions in the baby, particularly if infection takes place in the first 12 weeks, and that very much like German measles can, and therefore we have to test. The problem comes in those patients that have frozen, for example, sperm, who then develop evidence of having developed CMV, which is a very common condition in the UK. Up to 80% of people have been exposed to CMV. And if the evidence is on screening again 3 months later that CMV is potentially present in the sample, those samples have to be discarded, which is why in practice now we advise whatever pathway you're going to take to freeze your samples of sperm as gay men, because you get your sperm into sort of tip-top condition, you abstain from alcohol, etc., and then you freeze the sample. Now, just moving on to egg donor considerations, donors have to be in the UK under the age 35 or under and have a good egg reserve. They are likewise screened for the same conditions. Clinics will have different eligibilities as to whether BMI is an issue, but they will have a full genetic family history screening. If it's a known donor, there is a bit more flexibility. 3 points. Big decisions have to be taken around whether you use somebody you know, a known donor, or an anonymous donor. Another decision is whether you're happy to use frozen eggs, which is now becoming more the norm in our practice because there are more and more egg banks, and results using frozen eggs, frozen thawed eggs, is extremely good and has the benefit, if you're both intending to be biological parents, of being able to buy a sufficiently large number of frozen eggs for embryos to be created with half the eggs are fertilized with one partner's sperm, half with the other partner's sperm. And that gives you both the chance of sharing the same genetic egg donor parent, if you like, the egg biological part. And that is good. But just remember that those embryos cannot be transferred into the same surrogate. It's one at a time, and it's each biological parent in turn. Carrier screening occasionally comes up in the conversation. This is a screening test that some donor banks provide with extended screening for fairly rare and unusual genetic mutations that don't cause disease in the person, the donor, but can, if you as the provider of sperm have it, cause an increased risk to your child being affected with a condition. I would say hold back from carrier screening because it can lead to you sort of flagging up some conditions you weren't even aware you were carrying. Take genetic counselling before you have carrier screening. Make sure it's the right decision for you to go for a donor that has had carrier screening. It's not just launch in, oh, I want to do that because it is more expensive, but it's not something you have to do. With surrogacy, the considerations are here. You want potentially to create embryos that are frozen and then quarantined and then subsequently tested, because to find a surrogate, they need to know you have embryos available. PGTA testing of embryos I would recommend in the sense that this is genetic testing of embryos for abnormalities, because it will reduce the chance of an embryo being transferred into a surrogate and being identified as being genetically, and if an embryo is genetically abnormal, it can lead to failed cycles and miscarriage, whereas an embryo that's been identified as being euploid or genetically normal will have a higher chance of implanting. So it will shorten the time to pregnancy and reduce the stress. Most transfer cycles into the surrogate now would probably take place in a natural cycle, now that we've demonstrated that it's a very robust way of for performing frozen embryo transfer cycles, and that's what they tend to prefer. And remember that decision-making during any cycle of treatment lies with the surrogate. As clinicians, we would be speaking to the surrogate first not to the intended parents, and then that information can be shared. Now, in terms of embracing an inclusive approach, I've always said my tip-tops sort of recommendations is to consider all bits of paperwork, and I've listed them out here: registration forms, website, leaflets, posters, social media. Make sure you have things in your clinic that reflect all the communities that you serve, have gender neutral toilets, and consider carefully how you need to be, with your registration forms, thinking about all the ways that people might present, even those from the trans community. Provide a safe and sensitive space for sperm collection. Remember, it does not need to show, photographs in there, to fulfill the needs of heterosexual couples. It has to be somewhere that is sensitively considered for all that might struggle to produce a sample in the clinic, and might be from the trans community. And anticipate triggers during monitoring egg collection for trans men, for example, or for abdominal scanning. That's very, very important. A very brief word in tailored support for trans folk. They have a history of misgendering and rejection, so particularly be careful with pronouns and be sensitive, receptive, give them time. Many of the time we find there is an increase in neurodiversity in the trans community. So just make sure your information is provided in different ways, and give them a safe space for discussion and time for discussion. They can be easily triggered, and particularly around medical terminology to do with body parts. And in the discussions, consider how the eggs and sperm will be used in the future, and particular consideration should be given to them being likely to be used in a surrogacy arrangement, and make sure the screening is done at that time. Final note, education is key. In the clinical world we live in, healthcare professionals need good education, such as tonight's forum. Share knowledge, share case histories. We're going to hear from Jacob later. Give people good EDI training in your clinic, and make sure they're well briefed on HFEA regulation and the Equality Act.
Our next speaker this evening is Professor Nick Macklon. Nick is the Medical Director of the London Women's Clinic. The London Women's Clinic has clinics in London and in lots of other places beyond the capital. Don't be fooled by the name. And they were one of the very first clinics in the UK to provide fertility services for same-sex couples. Nick is a visiting professor at Zeeland University Hospital, and he's also co-chief editor of Reproductive Biomedicine Online. He's editor of several books, including 2 editions of IVF in the Medically Complicated Patient, and the textbook of periconceptual medicine and the manual of embryo selection. He's contributed chapters to more than 60 books and published more than 250 scientific papers. So I'm very pleased that he's got time to speak to us this evening, because he's a very busy man.
It's a great pleasure to join such a distinguished group of, I would say, pioneers in this field, to talk about the growth of services for LGBTQ plus community. Well, here I'm speaking to you from London Women's Clinic indeed, and as Sarah said, it's been around a long time. It's turning 40 this year, and over that period of time, and much of it over my career as well, it's been remarkable the changes that have happened in attitudes to treatment of LGBTQ plus community. But that hasn't just happened from talking about it. It's been about actions, and a number of clinics, again represented here this evening, have had an important role, like the LWC, in championing broader access to care. And LWC was there indeed from the very beginning. In fact, it was the first clinic in the country to interpret the welfare of the child clause that was put out by the HFEA in that time as being inclusive for LGBTQ plus community. I was working in the Netherlands at the time, where it was very, very normal to refuse same-sex couples, gay couples, even single women treatment for quite outdated reasons. And it has been remarkable to see the change over that period of time. But that has taken the courage and the initiative of many of the groups that you see represented here this evening to achieve that. So what I'm going to do over the next few minutes is just review some of the data that we have, outcome data on the treatments that are used, one of which is so clearly presented by Carole just now. And I think to set the scene, it's important to recognize changes that we're seeing in the contribution of the LGBTQ plus community to the work we're doing as clinics. And this will be, I'm sure, representative of clinics across the UK. As we know, the HFEA has said that more single patients and female same-sex couples are having treatment, but disparities in access remain, and I'm sure we'll be discussing that later. In our own data, we see that, yes, heterosexual couples are still predominantly the group that we're treating, but same-sex couples and single women are forming significant groups of that. And perhaps what's hidden in this data, which I can show you here, is the remarkable growth that we've seen, for instance, in same-sex couples coming from IVF here at London Women's Clinic over the past 4 years, with a 90% growth. So a lot is changing, attitudes are changing. The efficacy of treatment is probably part of that story. And altogether, we're seeing this as becoming a very major part of the care which we provide. So I just want to touch on some of the treatments, because it's very important that we understand what the treatments do, how effective they are, and in which patients they're most appropriate. So let's start with the most simple one, which has been the backbone of treatment of same-sex couples for many years, and that is intrauterine insemination. And a few years ago, my colleague Elena Linara Demarcacu, our embryology head, published this paper of a large study of 8,900 IUI cycles, of which 43% were carried out in same-sex couples, and was able to show that, as a form of treatment, this is going to be effective for many, as long as they stick with it. So particularly the under 35s, if they stay with them and don't drop out of treatment, around about 66% can achieve a pregnancy in this relatively simple way. But what we see from this kind of analysis, and this was, I think, the largest analysis at the time, was that the outcomes tend to plateau after 6 cycles. So this kind of data can help us counsel patients coming through as to whether or not this is the right treatment. And what we also see, perhaps unsurprisingly, is an age effect, such that in women above 40, only 3 cycles would normally be recommended before moving to other forms of treatment. So this kind of data is important that it's published, it's out there to guide counseling. Now, the other big change that's happened in more recent years has been this rise of inter-partner treatment. What's commonly known in the UK as shared motherhood. Again, I think LWC was one of those clinics that really got this moving about 15 years ago. And again, at the time, it was challenging a medical model of family building. I remember from my time in the Netherlands that the discussion with same-sex couples talking about this is, well, look, there's no medical need for you to carry the baby or for you to donate the egg, so we're not going to do it, which seems remarkably outdated now. And I'm glad to say has largely disappeared. And in the meantime, we've been able to help carry out more than 1,000 embryo transfers for this. And we published outcomes from a large study showing that after 172 embryo transfers, very good cumulative live birth rates can be achieved. And the well-being of parents and children have been confirmed in follow-up studies working with our collaborators in Cambridge University. This is just an update showing the outcomes of even more cycles that we've done. And we're seeing, again, very high cumulative live birth rates. So these are realistic options for people to achieve the family in the way that they wish. Now, I'm just going to touch on surrogacy because it's been dealt in some detail, but just to report our own experience that we've had more than 200 surrogates coming through over the last 10 years or so, 140 babies very happily born from it. 46% of these are for LGBTQ plus patients. And in fact, what we're seeing in terms of egg bank, that the rise of same-sex male surrogacy is coming now. You can see in the table on the left there that heterosexual couples are still the majority, but same-sex male are really coming up now and forming an important group. And we're getting extremely good live birth rates in all of the groups. And if you look at the cumulative live birth rates, we're seeing excellent results across the board. So again, this is a very realistic, effective treatment for many, many people. Now, why am I focusing on clinical data? And I think it's because clearly we need to reassure prospective patients of the validity of the option that they're choosing. But also, I think having data from outcomes also supports the shaping and the arguing for policies, because if we can show that the treatments we wish to carry out for our patients in this community work, then it strengthens our position to shape policy. And this is an example of perhaps of how we've been trying to do that here at LWC. So working with Kirsty Horsey, who, as many of you know, has been a leading advocate for change in the law around surrogacy. She joined us for a couple of years, and we published this paper of 179 cases, and we're able to draw some implications for policy and practice. These then extended into engaging in a debate as to the experiences of surrogates and intended parents, showing them to be generally extremely positive. And then from that, Kirsty published a couple of years ago this review article, which I would recommend, which is a review of the current global trends and national landscapes, and makes a very compelling case, in my view, for the change that we are seeking the Law Commission to bring in. And as co-chief editor of RBMO, I can't but fail to mention that this was the most clicked on article for our journal in the year it was published, showing the huge interest there is in reliable data-based information on surrogacy. Now, all of these techniques need to be mature before they can help transgender patients, and they are now. And this has allowed clinics like us to really start offering treatment to different combinations of families. And I've just listed some here. We've done 16 cycles in where the patient was cisgender female and the partner was transgender male using donor sperm. We've done a cycle in a patient who was a cisgender female, the partner was a transgender female using IVF with frozen partner sperm. 2 cycles where the patient was a transgender male with a cisgender female partner. And indeed 1 cycle where both were transgender, a transgender male and a transgender female, using donor sperm and a surrogate. And again, if you persist with treatment in these patients, most of them will happily succeed. And that last case, if you're interested, we've recently published in RBMO, in which we described this couple, a 36-year-old transgender male who underwent preservation of their eggs and embryos in 2015, returned in 2018 with a transgender female partner. They underwent surrogacy treatment, a healthy baby was born, and I'm delighted to say another baby followed. So all of these techniques that we've been discussing come together to make this a possibility and hopefully a new normality on the UK fertility treatment scene. Now, as I started in my talk, we wouldn't be here without the courage of people to forge ahead with these treatments, sometimes against quite strong headwinds, whether that be regulatory or whether it might be interpretation of regulations or indeed groups with particular views on the matter. And it does take courage to lead, and I think London Women's Clinic has been one of those who's done that over the years. We've been very fortunate, I think, to operate in a very regulated environment, but one which keeps itself informed, but makes it very clear where the boundaries for care are, and is trying to be as inclusive as possible. And of course, that is the HFEA. And then to finish off with, of course, the Progress Educational Trust, which is such a strong and vocal and influential advocate for the LGBTQ+ community in fertility care, publishing courageous papers, such as this, again, from Kirsty Horsey and Zaina Mahmood, which I believe is making an important contribution to debate, and we all need to continue to do that.
So we now, following on from Nick, have 2 speakers. We have Nancy Kelley and Laura Rose Thorogood. Nancy is Executive Director of DIVA magazine, which is the leading magazine for LGBTQIA women and non-binary people. And she was previously the Chief Exec of Stonewall. And Laura Rose is the founder of LGBT Mummies and Proud Foundations, and she's a contributor to the book Supporting Queer Birth and co-author of research into increasing use of IVF by same-sex female couples. And both of them are the spearhead, really, between the Fertility Justice Now campaign, and that's what they're going to both be talking about to you now.
Thanks so much, Sarah, for giving us the opportunity to speak to everyone tonight. I'm Nancy, my pronouns are she and her. I'm a mum and an LGBTQIA campaigner, and I'm going to talk about a bit about the history, the context and the campaign. I'll try and be quick. I want to get you fired up, but I want to hand over to Laura Rose, who is working every day with prospective parents and can really bring that to life for you. So I'll try and do my bit quickly. I think the first thing to say is the Fertility Justice Now campaign is about the whole community. So when we say LGBTQIA, I don't want to make assumptions that everybody is familiar with what all of that means. We're talking about lesbians, bi men and women, gay men, we're talking about queer people, we're talking about trans people, we're talking about intersex people, we're talking about ace people. So we're talking about a very wide range of prospective parents or families. And we're talking about some people that really don't get much of a look in this conversation. What's really important to the Fertility Justice Now campaign is that we are fighting for a sort of fair and equal experience of family formation for everybody. We're not just fighting for the families that the majority find easiest to think about and easiest to relate to. So that's a really important principle for us. And it relates a bit to history. So homophobia, biphobia, transphobia are all intimately bound up with family and the kind of concept that LGBTQIA people shouldn't be parents, aren't safe around children, is really baked in to a lot of hostility towards our community. And that matters. It means that when we approach services, we approach them often with a really high degree of fear or worry. It also means that it's an issue, LGBTQIA parenting, that our whole community will get behind, whether or not we want to become parents ourselves. And to kind of unpick that a bit more, our history is about being completely excluded from consideration and care. And I was really interested, Nick, in you talking about London Women's Clinic's very long history in this area. And I'm thinking about 40 years. So to give a sense of how kind of close the most painful parts of history around family formation for our community are, they were still removing the children of lesbians who left male partners into the 1990s. So London Women's Clinic was already doing treatment of same-sex female couples at a time where older generations of women like me were leaving their male partners and having their kids removed for being lesbians by the family courts. So I think it's important to have that kind of sense of how close in time and how powerful that sense of, are we going to be supported in our family building journey is. What does it look like for us now? What are the issues that we're touching on? Well, there's still really bad access to information. If you approach your GP at the start of your kind of fertility journey, you can be lucky. You can meet a GP who knows all about your route to family building, and you can meet a GP that doesn't know anything about how someone like you starts a family. You can also be part of a community where access to information is just structurally bad. So previous speakers have spoken about the trans community. There's very little information available around fertility services for trans people. Most of the really good studies, particularly on transmasculine people, are in the US. So very often in the UK, transmasculine people don't even get told, do you know, it's not just about fertility preservation for you. You can actually just have a baby if that's what you want to do. So there are some very basic informational problems that we still experience in our communities. The care is patchy and poor quality sometimes. Again, you can be lucky and have a wonderful clinic, whether it's a private clinic or an NHS clinic, and you can be really, really unlucky still. There's a real lack of choice. So you can be pushed into a clinic setting, for instance, because it's no longer possible to legally access sperm at home, which is something that a lot of people would choose if it was still available to them. There are big structural barriers. We've touched a lot on the IVF system and access to IVF. But despite the commitment in the Women's Health Strategy, there are still people paying upwards of £25,000 of private treatment in order to access one round of IVF on the NHS. And for many people, that just means they cannot start a family, or they cannot start a family in the way that they would choose. And there are exclusive systems that just don't work. I would say you could think here about things like birth registration. If you are a trans parent, if you are platonic co-parents, if you are surrogate parents, or if you're forming your family through surrogacy rather, our processes for birth registration, they just don't work very well for you and your family. And similarly, you can have whole system failures. So I would say the whole system is beginning to respond more slowly to the needs of trans prospective parents, but there's still very little engagement around intersex prospective parents. So this is kind of the picture that we're currently living. And the goal of Fertility Justice Now is to set out a positive vision of where we should be, a fair and equal access from the point that you talk to your doctor to birth and beyond for every part of the LGBTQIA community. And we really want everybody to get involved in the campaign. So Laura will show you how to do that, but it's very easy. At the minute, you can check out our campaign asks. We want you to use PET's amazing policy tracker to find out if you're one of the lucky people with good local services or terrible local services. We want you to write to your MP. We want you to get other people to write to their MPs. And for those of you that are attached to organisations, we'd love to work with you as supporters of the Fertility Justice Now campaign. So that's a kind of overview of what the campaign is, but also kind of where it comes from. I'm going to hand over to my colleague Laura Rose, who is working day in, day out with LGBTQIA prospective parents. And it's those experiences that really drive our campaign forward.
Thank you, Nancy. Thank you, everyone, for having me. And apologies for the late joining. I am juggling little ones as well. My name's Laura Rose. My pronouns are she, her, and I work alongside Nancy on the campaign and many others. So we're a collective of organisations, but as Nancy said, at the heart of it is the lived and living experience of queer people who just want to have the right to access fertility funded treatment in their local ICB, in their local region, in an equitable and equal way. And the problem is around informed choice and consent. Not everyone wants to have IVF. Some people want IUI. It's less invasive. It's not something that they want to choose to do. So we're talking about lots of different facets of the manifesto, which you can download from our website under live campaigns. And within that manifesto, we list our asks of the government. Within that manifesto, we want that to be a long-term plan. We completely understand and appreciate that many of our asks are long-term. They're not quick wins. They're things that will take time and will indeed need a lot of co-production from the NHS, Department of Health and Social Care, the government, and lots of localised NHS trusts to come together to create a cohesive and robust process for queer people to have a seat at the table, to be represented in those policies, but also ones that reflect us. Not just same-sex couples, lesbians and gay dads, as systemically, unfortunately, that systemic race discrimination is still there, because often it is same-sex couples that are obviously the first people that come to mind, lesbians, gay dads, etc. We want to ensure that everyone has access in their given right. So trans, non-binary, intersex, ace and others within the community. So within that manifesto, what we also want to highlight to people is the barriers and implications that we face as a queer community. It's not just the fertility funding provision that we have difficulties with. It's the ongoing barriers and systemic discrimination that we get through the healthcare service, society, the laws we have to go through, the hoops we have to jump through to create our family. Now, fertility justice, we believe that everyone deserves the right to create their family by their first chosen route if medically viable. But that's something that is being held back from us. And when it comes to an equality perspective, it's something that we are not acquiring right now. So Nancy and I and the others within the collective, including Sarah and Progress, are really working hard, but we do definitely need your help because we need to highlight the disparities. We need to highlight the real lived and living experiences of those and the impact it has. It's not just physiological, it's not just psychological, it's the financial, the economical impact on us as a community, but also economically to the government. We're at the lowest birth rate as a nation since 1938. We are not replacing the people that are passing with new children, babies. And at the moment, it's something that as a community, 77% of our community, 18 to 34, are willing or really looking forward to having a family of their own. People ready and waiting to support the economy, become taxpayers and give back to society. We're not being given that equal chance. So we need to consider that impact on our community, that physical, psychological and economical impact that's happening to us alongside the systemic discrimination that people experience. It's not just homophobia, biphobia, transphobia like Nancy spoke of. We're also talking about systemic racism, ableism, those from areas of social deprivation, and of course that intersectionality of many of us queer people ticking more than one box. It's incredibly crucial to remember that sometimes people are dealing with those multiple barriers and those multiple hurdles that they have to jump through. So if people can consider writing to their MP on our website, the MP template letter is there. You just have to put your MP's name and address on there and their details and your name at the end, and you can send it through by post, by email. You can also post about it on social media. We will be avidly and passionately posting about it over the coming weeks, talking through our manifesto points and what that means for the community. But we need all allies, clinics, sperm banks, anyone in society, friends, family members, support networks, the workplace, to come together to shout about this, because we're at the precipice of a point whereby our community is growing louder and our allies are growing louder. And because there is also other campaigns happening, Fertility Access, which is run by Fertility Action Network, and looking at them from a heterosexual point of view, if they get access, we deserve access too, hence why we're working so closely together. So we've got lots of wonderful MPs that are backing us and talking very loudly within government and parliament, but we do need as many people as possible talking about it, supporting us and being behind us. Not always speaking for us as well. If you know a trans person, you know a queer person that is impacted, speak to them, but listen, raise and amplify their voices, ensure that they are heard by whichever way possible, because unfortunately the most marginalised within our community are often forgotten. And that's what Nancy and I, Sarah and the others want to ensure most prolifically, that whatever happens with this campaign, it is for all of us, not just for some of us. So thank you very much for having us. And if there is any questions, you can email either myself and the team at LGBT Mummies, Nancy at DIVA, or you can message us on socials, and we'd love to hear from anyone that wants to support in any way possible.
So I will move on now to our next speaker, and it gives me great pleasure to introduce Dr. Marcin Śmietana. I hope I've got that right. So Marcin is someone that we've worked with on other projects, but not on this topic. He is a research fellow at the Foscari University of Venice, and he is an affiliated lecturer at the University of Cambridge. He's a contributor to several books, including The New Reproductive Order, which isn't out yet, but it's available on pre-order from New York University Press, and also Relatedness in Assisted Reproduction. He is co-editor of a special edition of the Reproductive Biomedicine and Society Online, which was on the theme of making families, transnational surrogacy, queer kinships, and reproductive justice.
I'm going to focus on barriers and considerations in gay men's use of surrogacy in the UK, which might, however, refer also to other members of the LGBTQ community. And I'll be drawing on a study I carried out between 2020 and 2022 as part of a Wellcome Trust-funded grant led by Professors Sarah Franklin and Marcia Inhorn in the Reproductive Sociology Research Group at the University of Cambridge. And I'm also carrying out follow-up research on it right now. So our meeting today reminds me of the event I co-convened with my colleagues Natasha Tanna and Hakan Sandal-Wilson at the University of Cambridge back in 2021. And this event was called Current Issues for Queer and Trans Families. We invited LGBTQ parents from across the UK who were activists and represented adoption, donor conception, co-parenting, international surrogacy, and surrogacy in the UK. And one conclusion from that meeting was that despite one of the most progressive frameworks for queer family making in the world, in the UK still today, if you're gay, you're lucky to be a parent, as Alan White, the trustee of Surrogacy UK, said. And this means that surrogacy and that sexuality and gender still constitute a barrier to achieving fertility today. We know that this is changing. The first male same-sex couple got IVF funding on the NHS Scotland in 2020 as part of an altruistic surrogacy arrangement. However, it's changing slowly and not everywhere. In October 2023, the UK government announced an upcoming IVF law change that would benefit same-sex couples as well as people living with HIV. As a result, since 2024, people with non-transmissible HIV have been able to access IVF treatment in UK clinics. However, as has been said earlier, female same-sex couples continue to have to self-fund artificial insemination before accessing the NHS. And for male same-sex couples, the NHS, with the exception of Scotland, generally does not fund surrogacy arrangements or associated fertility treatments such as IVF. And as Kirsty Horsty mentioned here earlier and colleagues found, over the last decade, surrogacy cases increased 4 times in the UK. And this was due to a large extent to gay men's use of surrogacy. The authors attribute this increase to changing social attitudes about LGBTQ families and to an increased awareness of the possibility to undertake surrogacy in the UK. So in this context, between 2020 and 2022, including follow-ups right now, I carried out a qualitative interview study that included 30 families based in England and Wales, created by gay men through surrogacy. 25 of them used altruistic surrogacy in both its traditional and gestational variants, and 9 went overseas to the UK, to the USA or Canada. They all had young children in the process of surrogacy. And they were all UK citizens or residents with a range of national as well as ethnic and racial identification. And this is not the main subject of my short talk today, and we can also comment on it in the discussion as well. But I just wanted to flag that the parents' skin color mattered as they matched it to the egg donor's skin color for 2 reasons: to create a feeling of belonging between themselves and the children, and also, which might be more relevant to the question of barriers that we're discussing today, they wanted to avoid potential stigmatization or questions from people around them, which with my colleague Franz Winden-Twine, we called preconception stigma management. And on this slide, you can see some quotes that show it, as Theo, the second quote, said, "Our kids already are going to be different. We want the least amount of questions that ask us to validate our own family existence." One of the main findings from my research was a change in reproductive consciousness that most of the study participants had experienced in their lifetime. From thinking that being gay meant the possibility of never having a family, to learning and realizing that it was indeed actually thinkable for them to identify as gay and become parents. For example, that happened to Nick, a 40-year-old gay dad of 2 children, whose words you can see on the slide. On the contrary, only some of the youngest interviewees, who were in their 20s, did not always go through this consciousness change, as they assumed from the very beginning that it wasn't actually mutually exclusive to identify as gay and have children. However, one of the main findings from this research, and here I'm getting to the core of my short talk, were spreadsheets, and specifically surrogacy expense spreadsheets. Here you can see Harvey and Oliver's expenses, of course, anonymized and shown with their permission, for an altruistic and traditional surrogacy arrangement in the UK, summing up to almost £13,000 of necessary expenses, such as maternity clothes, compensation for the surrogate's lost earnings, food for her own children when she wasn't able to cook at the end of pregnancy, or travel costs for home insemination in another town, as they said, quote, having to respond at short notice to Debbie, saying, Debbie is the surrogate's pseudonym, "I'm ovulating, you need to get up here within the next 48 hours to produce 3 samples over 3 days," end of quote, because that was a traditional surrogacy arrangement with home inseminations in that specific case. Still, they needed the £13,000 for compensation. However, in their second surrogacy arrangement, home insemination didn't work. So Harvey and Oliver had to recur to IVF in a fertility clinic, and as a result, their expenses doubled. Alongside the almost £12,000 of surrogacy expenses, they also needed to cover almost £14,000 of IVF expenses. So this summed up to a total of over £25,000 for their second surrogacy arrangement. And this didn't even include egg donation, given the surrogate used her own eggs. Some other study participants paid even up to £50,000 for a gestational surrogacy arrangement with egg donation in the UK, including donor egg costs, an IVF surrogacy cycle, embryo creation and storage, as well as compensation of the necessary expenses for the surrogate. And you may not be able to discern the details of this very long surrogacy expense sheet that Paul and Federico, based in London, used for their gestational surrogacy arrangement in the USA. But it's just to give you an idea. In this study, 9 surrogacy arrangements happened overseas on a commercial basis, in particular in the USA. And in those cases, total expenses began at approximately £100,000 per surrogacy arrangement and often went much higher. They were all gestational surrogacy arrangements using donated eggs, as is common in America. So this analysis led me to formulate the concept of spreadsheet fertility, that is the kind of fertility that needs to be managed, pushed, driven in order to happen, and which requires almost managerial and entrepreneurial skills, deliberate and strategic planning, as well as in many cases, significant economic resources. For example, Harvey and Oliver, whom I mentioned earlier, saved approximately for 7 years due to the costs involved. And Paul and Federico remortgaged their house thanks to their status as homeowners. And this happens both in gay father surrogacy families and in the heterosexual world of IVF as well. You can read in greater detail the chapter I wrote on this topic in this new book that's coming out in April, as Sarah said, called The New Reproductive Order, edited by Sarah Franklin and Masha Inhon. This also means that in particular for gay men, access to fertility treatment and to parenthood is mediated by social class or socioeconomic status, because none of the interviewed families had a disposable annual average household income below the UK average. So does it mean that there are no low-income gay parents through surrogacy? Possibly. What is more, none of them received any IVF funding from the NHS in England or Wales, where the interviewees were based, whereas maternity care was properly provided, because that's a different part. So in a context with public funding for fertility treatments, such as the UK, despite the existence of altruistic surrogacy, the barriers for gay men becoming parents continue to exist. And for sure, they do make it difficult to implement one of the key claims of queer reproductive justice, which we also formulated with my colleagues Caris Thompson and Franz Windens-Twine in the volume you can see here. That is, identifying as LGBTQ+ should not place exceptional demands or restrictions on one's access to reproductive care and services, yet it does. In terms of solutions, what can we do to mitigate these inequalities? Should we campaign for NHS funding for IVF in surrogacy arrangements for all LGBTQ+ and for all people? Should we promote traditional surrogacy arrangements beyond the clinic in those cases where it is possible and desired, of course, because that's not always the case? And we should for sure valorize equally multiple queer family forms, including different kinds of surrogacy, as well as co-parenting, adoption, and other. And I think that these points are quite in line with the Fertility Justice Now campaign that has been discussed earlier. So I'm looking forward to further exchanges and thoughts that anyone here might have also on the part of fertility clinics, which are a very important part of the process, as has been said.
So now our next speaker is Jacob Stokoe. Jacob is the founder of Transparent Change, or Transparent Change. It's a good, clever play on words. I love a pun. And which is a not-for-profit, which is fighting misinformation and disinformation about trans people and gender identities. And he's doing that through honest, accessible, and engaging training. Jacob was motivated to set this up after his experience of maternity services as a pregnant trans person. During that time, he had to provide education to every member of staff that he came into contact with. And those were the very staff that he needed to have support from during a very vulnerable time. and he is also the author of commentary on LGBTQ plus parenting.
I'm talking today about access to fertility care for trans people. It's going to be a bit of a whistle-stop tour because it's only 10 minutes. This is really kind of aimed at fertility clinics and people who are working in fertility care to kind of just understand, just how many of us there are and the needs that we face and some kind of quick understandings of what to do. As Sarah said in my introduction, I am a trans birthing parent, and you can see here a photo from my first birth. You can tell it's my first birth because I still had hair. And this is just a really beautiful and very trans moment of me having literally just given birth to our daughter. And here's a photo of me pregnant as well. There's not really a repository of trans pregnancy photos, so I rely on my own. So what does the research show? I think people assume that there aren't many trans people who give birth. I think people assume that there aren't many trans people, but the CQC maternity survey has consistently found for the 3 years previous to 2024 that 1% of people who had a live birth under NHS care had a gender different than their assigned sex at birth. That means they would come under the trans or non-binary community. That number has risen in 2024, and it is now 2%. 2% of people who give birth under NHS care have a gender that is different than their assigned sex at birth. It's also just interesting to know that 2% also prefer to not disclose, which means we can only say for certain that 96% of people who give birth are women. It's also really important to know, and so these details are looking at birth initially. I will talk about the limitations of the data. We also know that trans people are very unlikely to want to access certain types of care, particularly perinatal care. And this is relevant because if you're struggling to enter perinatal care because of the gendered aspect of it, you may not be able to access fertility clinics for those same reasons. But 30% of trans non-binary people don't access any perinatal care at all. And it's really important that we talk about intersectionality. I think Marcin mentioned it about how when you have more than one type of marginalisation, care becomes much harder. 46% of trans people of colour don't access any amount of perinatal care. But let's go zoom back out a bit. So we've recognised that trans people are actually giving birth. How do we get there? Well, we know that these numbers aren't considering the partners of people who give birth. So I think in, what was it? I took a note. The doctor from London, the London clinic, was saying about how the partner of the person giving birth was the trans person. That's very, very common. So we know that 2% of people giving birth are trans. Okay, so how many people giving birth have a trans partner? We also know that we're more likely to access fertility clinics than our cis counterparts. Obviously, because we are LGBT, but also because we're in families that may not have all of the ingredients to make a baby, but also because of fertility preservation, and that's something that our cis counterparts may not need to access in quite the same way. And also, the other thing that's not here on this data is intersex people and their experiences. I mention this because a lot of intersex people may have a trans identity, and there's a lot of overlap in terms of the fact that when we consider sex as a spectrum and not something of simply two binaries, trans people may fall somewhere outside of their assigned sex because of medical interventions. So when we consider trans experiences of fertility care, there are so all of the ways that LGBT people are impacted more broadly impact trans people because we are in LGBTQ plus relationships. No matter which way round you put it, if we're accessing fertility care, we're not going to be coming in a straight capacity. Even if the people themselves are straight, you still may have to use, for example, the cis woman who has a trans man partner. They may both identify as straight, but they are accessing care because of not having access to all the ingredients, because of being outside of kind of a cis heteronormative bubble. And so all of the ways that LGBT people are impacted, we are also impacted, but we also have some unique things that come with it as well. I've got some quotes that come up here, and I'm going to talk more broadly. So initially we have staff reactions, and the quote, "My family was called freaky, he called us freaks twice." And that the issue about staff reactions there is it can be the barrier before people even walk in the door because of the fear of those reactions, but it can also be the thing that turns people around so they never come back again. or that stops them because actually that was really impactful and harmful to them. There's also paperwork. The quote here, "We sat and crossed everything out and replaced it with the right words." I experienced this in perinatal care as well. Everything says mother, everything says father, single female, I really liked what Carole said about, having language like provider of sperm, provider of eggs, the person who's going to be pregnant. If we're talking about anatomy and the specifics, that's a really good way of kind of using neutral and relevant language, and also being really clear about who you're talking about. Because if you say dad, who is that within this within that dynamic? Education is another really big one. Like was mentioned in my intro, I had to do a lot of educating with every single person I came into contact with, and it wasn't the kind of education that was, here, let me tell you about me and my complex needs. It was, this is what it means to be trans. I had one member of staff say to me, "But weren't you born a woman?" And it was this then having to say, well, nobody's born a woman because that's a fully grown adult. Yes, I was assigned female at birth, and then having to kind of go back. Very basic things about trans physiology, about what chest surgery is, what lower surgery can be, and things like that. But also things like if you are a trans woman and you're wanting to provide a sperm sample, if you have been tucking, which is something that a lot of trans women do to navigate dysphoria, that will be keeping the testicles inside the body or very close to the body, which then heats up the sperm. So if you are tucking, you need to know to not do that for sort of, the guidance varies, but 3 to 6 months before you then give your sample. I'm sure Carole can give better information on that, as that's her area of expertise. And so if the trans woman providing her sample does not know that, and the person taking the sample does not know that, you're then left where someone's unable, literally, to provide a sample that's strong enough. There's also misgendering. Now, obviously, the quote here is, "It was during COVID, so I could wear a mask and could pass better." This was about somebody wanting to access that space and not be relentlessly faced with misgendering when people were speaking to her directly. But misgendering, I classify into 2 forms. There's direct misgendering and indirect misgendering. Direct misgendering I very rarely receive because I look like you should use he, him pronouns for me. I'm happy with he, him pronouns, and so people tend to use the right language for me. Indirect misgendering is when you are accessing a space that, or you're receiving things to you in the form of letters or whatever, where it isn't being directed to you directly, but it's assuming that you are a particular gender by using that service, entering that space, for example. So when I had to access maternity services, I was relentlessly, indirectly misgendered. I got letters that said all women should come for a 12-week scan. And so it's like, okay, well, do I go? Am I misgendering myself by going? Obviously, I went for my scans. But I had to make that conscious decision to enter a space that was misgendering me. And direct misgendering is so incredibly harmful. Indirect misgendering, an occasional time of happening can be manageable, but that relentlessness of it, and especially if you think of somebody going through fertility treatment, the positive outcome of that is going to be then accessing perinatal care. And so you've got this kind of, that you are going to be facing something that's even harder afterwards. There's this kind of long stretch of time where you're relentlessly getting misgendered. And clinic choice is something that, as a trans community, we talk about in these spaces, because if somebody's had a bad time of it, they then will let other people know about it. The Agora's got a really great reputation. I know a lot of trans people go to those spaces. There are other clinics that perhaps word of mouth and things. But it also can be that people's clinic choice is limited because they've walked in, they've had a bad experience, and they've had to turn around and leave. And so that first initial, or gone on the website and it's not inclusive, there can be these barriers before you even start treatment. And so if we consider barriers to care and what you can do, I'm just going to do these really, really quickly because I'm aware time is short today. Gendered language is, of course, an issue. And I think people think that it's really, really complicated, but most of the time, accurate language is the most inclusive. I can go into detail about that if people are interested. And when you're thinking about your own spaces, consider the service user pathway, which is including physical spaces, letters, and things like that. For individuals, it's very simple. You just use the language that's right for the person in front of you. But questions are important, and that's because of two ways. One, it's important because you should ask questions to find out what language do you use for your body, what language do you use for your partner, what parent names are you wanting to have, things like that. But also know that questions can be incredibly damaging. I went for a blood test and was asked about my genitals. They didn't need to know that. That's not just the one time that's happened. That's happened so much I got business cards made so I could give to people to say, please don't ask intrusive questions. We may be your first trans person, you're not our first inquisitive person. Misinformation is rife, and so the important thing is to get educated. Obviously, there is specialised training, and we do provide that, but we're not the only people. And keep up to date with research, and keep up to date with the language as well. And be able then to inform your service users, because we as a community are having to, find this information out, but we don't always have the means to get as educated as possible. And the other thing is about using critical thinking, and this is just because there is so much misinformation and disinformation around, really driven by transphobia, driven by this rhetoric that we're somehow harming people by existing, when really we're the ones who are genuinely at risk of harm. We don't take anything away from people by existing in these spaces. And the final barrier that I'm going to briefly touch on today is fear, and this can be fear from clinicians, from staff, because you don't know how to get it right and you're worried about that, which again, education can really help with that. We do a lot of work on how to get it right, but also what to do if you get it wrong. But also fear from the trans people, because as I say, you can get to a website, if you don't see something inclusive there, you're going to turn around. So visible inclusion is really important. Share your pronouns, have inclusive language online and on signage, and make your spaces as inclusive as possible.
So we'll move on now to our final speaker, who is no stranger to pet events. In fact, she spoke at the very first event that I produced at Pet with Sandy back in the day in January 2008, which rather ages us, Natalie, I think. And then back then we were campaigning for the need for a father to be removed from the Human Fertilization and Embryology Act, something that was successful. Anyway, so Natalie Gamble is the director of NGA Law and founder of Brilliant Beginnings, which provides a not-for-profit surrogacy service. And she is a contributor to the Resolution Family Law Handbook, and also to the book Regulating Reproductive Donation.
And I'm really glad that you mentioned that, Sarah, about that event in 2008, because I was going to just reminisce a little bit about that, but it definitely does make us far too old. But that very first pet event at which I spoke was on the eve of the vote to include same-sex parents in the Human Fertilization and Embryology Bill. That was the legislation that enabled two women to be recorded together on their children's birth certificates for the very first time. And as Sarah mentioned, it was also the legislation that removed the requirement for UK fertility clinics to consider a child's need for a father, something which decades before that had deterred fertility clinics from treating single women and lesbian couples. So although it was not impossible to conceive children as an LGBTQ family before then, recognition of same-sex parents as their children's legal parents really opened the door to making family building through fertility treatment an accessible option. The bill and its changes for lesbian parents caused huge controversy at the time. I think even former Tory leader Ian Duncan-Smith described it as the final nail in the coffin of the traditional family. What drama. And interestingly, but probably just because it slipped below the radar, the legal changes which also enabled two men to apply for parental orders, which in practice transformed gay men's access to surrogacy in the UK, attracted no controversy at all at that time. So those were exciting times in which same-sex parent families were recognised for the first time and treated equally, and it felt like a really transformative moment. It came just a couple of years after civil partnership, and it would still be another 6 years before we got same-sex marriage. So at that time, LGBTQ families were not visible in the media in the way that they are now, and the world felt very different. And law change at that time was driving social change as much as the other way around. But let's roll on 17 years to 2025, and the UK is a very different place. Social change has happened at pace. There is broad acceptance of same-sex marriage and parenting, TV ads routinely featuring non-traditional families. I understand even Peppa Pig has a character with two mummies, apparently one who is a doctor and one who can cook spaghetti. So there's more openness, more acceptance of transgender identities, and I say that not to diminish some of the current backlash. But the modern UK is a rich diversity of family types, and with all the evidence showing that children who are loved thrive no matter what their family structure. And in that context, the changes that were made in 2008, although very positive at the time, are no longer meeting the needs of LGBTQ families. And in my brief 10 minutes, I wanted to flag 3 areas in which I think reform is desperately needed. So firstly, surrogacy, which is the main route to biological parenthood for gay dads, although of course also needed by other types of parents, straight couples, single parents, and so on as well. Access to surrogacy in the UK is incredibly challenging. There is a significant shortage of surrogates and no clear and supported process for finding one. The UK's non-profit surrogacy organisations do an excellent job with limited resources, but none can offer any certainty about when or even whether intended parents might find a match. It can take years, and for some, it never happens. Many parents instead look for surrogates via unregulated online forums, or they go overseas. And this all comes down to the fact that UK surrogacy law was written from a policy standpoint of discouraging rather than regulating surrogacy. No matching for profit is permitted, advertising is banned, surrogacy agreements are unenforceable, and a criminal offence for lawyers to negotiate. The surrogate and her spouse are the legal parents. This all means that the onus is on parents to find their own surrogate somehow and to navigate the surrogacy process informally. The legal process only kicks in after the baby is born, enabling intended parents to apply to be recognised as their child's legal parents via a court process which takes 6 to 12 months. Around 250 children a year are born through UK surrogacy, so it does work for some, and it's worth emphasising that arrangements are typically very positive and disputes are incredibly rare. However, it's not surprising that growing numbers of intended parents are instead looking abroad to places where they can engage a professional agency to match them with a screened surrogate within a clear timescale and can enter into a surrogacy arrangement with legal certainty. Those who can afford it go to the US, where surrogacy is safe, ethical, and generally very well managed, but it costs upwards of £250,000 and so is not accessible to most gay parents. Other international surrogacy options are limited, particularly so for gay men, and may involve countries where the law is grey and there are few ethical safeguards. The Law Commission made proposals for surrogacy law reform in 2023, and as yet there's no sign of them being implemented. But if we are truly to transform access to safe, ethical surrogacy in the UK, the Law Commission proposals do not go anywhere near far enough. Secondly, transgender parents, who are at present just excluded from the UK's fertility laws. Despite the fact that the Gender Recognition Act predated the HFE Act by 4 years, it seems that in 2008, no consideration was given to the possibility of parents conceiving children after having obtained a gender recognition certificate. At the same time, the law was written in an incredibly gendered way. Throughout, the Act refers to the woman receiving treatment, and there are separate sections dealing with male and female partners who are respectively legal fathers or second legal parents. The effect for transgender parents is bizarre outcomes. A trans man who gives birth must now be registered on the birth certificate as his child's mother, and yet a trans man who is married to a partner who gives birth can be registered as the father. For those who fall on the wrong side of the law, a simple application for their child's first school place, which requires production of a birth certificate, has become an outing event, forcing the disclosure of a parent's gender history to their child's new school secretary, even though it is supposed to be the most private and protected information. But even for those who fall on the right side of the law, There is uncertainty about their right to register their children's births using an appropriate title, anxiety about what should be disclosed, and I am seeing growing fear about whether birth registrars may become less accommodating because the law is so unclear. This desperately needs to be addressed. We need law which reflects the reality that trans parents exist and that they can and do conceive children. Finally, I wanted to talk about multi-parent families. These are families which are particularly common within the LGBTQ community, sometimes where lesbian couples team up with known fathers to conceive a child in a co-parenting arrangement, sometimes where parents are in a polyamorous relationship and living together as a throuple or more. UK law at present does not recognise or include such families, since the law allows a child to have a maximum of 2 legal parents. I sometimes get asked whether in advocating for LGBTQ families we are putting adult desires before children's needs, and I wanted to address that very clearly. The reality is that all the families I have described are real, they exist, and they are a lived reality for a growing number of children. And all the research evidence shows that these children suffer no harm and are thriving in such families. Ensuring that LGBTQ families have proper legal recognition is entirely about what is best for the children. They are entitled to a secure legal connection with their parents. It means the right to be financially maintained by a parent who leaves, the right to inherit from a parent who dies, and the simple everyday right to have the adults who care for them be able to make the decisions needed to safeguard their welfare. Children born in LGBTQ families need, in short, to be treated in law just like every other child. So what is the answer? As I have said, we need a braver approach to surrogacy law reform than the Law Commission has recommended. There is a lot more to say on this, but while the Law Commission's recommendations are broadly positive, they will do nothing to transform the difficulties around access to surrogacy in the UK. We don't just need at-birth parentage for the few parents who are able to find a surrogate via one of the UK's non-profit organisations, and we definitely don't need an even more restrictive approach to surrogate expenses. What we need is to make surrogacy more attractive to potential surrogates in the UK, while also making absolutely sure they are safe and the process is managed ethically. In short, proper regulation. Yes, there are ethical risks in surrogacy, but we need to engage with those constructively to address them. This is a sensitive issue which needs thoughtful and practical reform, and it's really important that we don't allow the debate to descend into simplistic culture wars. We also need law which properly recognises all family forms. The 2008 changes were inclusive in the sense that they grafted same-sex parents onto the law that already existed for straight couples conceiving through sperm donation and surrogacy. But what they created was a complex system of law with different rules for each conception scenario. What we now need to reflect the increasingly rich diversity of modern UK families is a simpler approach. My suggestion is to draw on the experience of Canada and many US states where legal parenthood in assisted conception cases is based on the simple principle of intention. UK law could say quite simply that where a child is conceived through assisted reproduction, his or her legal mother, father, or parent is whoever at the date of the insemination or embryo transfer intends to be the child's legal mother, father, or parent. Such an approach would work for surrogacy, for parents through gamete donation, for transgender parents, and for multi-parent families. And it's desperately needed because unlike in 2008, law change is now lagging behind social change.
So the first question I'm going to take is from someone who's anonymous, and they say, what do you think are the common arguments that the public gives that is preventing provision of fertility treatment to the LGBTQ plus community, where they have a chance of starting a family life? Because it seems that the society isn't still quite open to giving fertility treatment to LGBTQ, although, as we've seen from the statistics presented before, that it has been increasing for the past 4 years, and they've not directed that at anyone in particular. Nancy's kindly typed an answer for me from her, but I'll go to I'll perhaps go to Carole first to see if what your opinion is on this about the public's attitudes to this that may be preventing it. Do you see that at all? Perhaps not in Brighton.
It is interesting because I think the landscape's changed certainly in the last few years because there has been a lot more openness and discussion in the media about what same-sex parenting looks like and how children are equally well cared for. That there is definitely no reason to give patients that come to us for help a different answer, that they shouldn't be treated. I have noticed, obviously working in Brighton, a completely different attitude from our ICB, who fund donor sperm treatment for lesbian couples and single women, who fund people from the trans community fertility preservation. And there isn't, still a lot to be done for those wanting to create embryos for surrogacy. That's work in progress, I think, but there is definitely a different attitude, and I think it is around education, both of people in the community and society, but also of ICBs who seem to that actually dictate funding. They dictate whether fertility funding will take place, and so ICB stands for Integrated Care Boards. They're the ones who decide whether they will actually fund IVF treatment, and they need educating a lot.
They certainly do, having read their policies and the way they tie themselves in knots with their language, I have to say. Does anyone else want to come in on this one? If not, I shall read Nancy's answer, which is in a second, I'm trying to find it. She's done quite a few. So she thinks there are two areas where attitudes make a difference, she says. One is that there is still a sense that the LGBTQIA plus people are not natural parents, and so we should be grateful for what we get as opposed to be entitled to what everyone else gets. I think this can influence professional as well as public attitudes. The other is that hang on, sorry. Someone just ticked in. Someone's just put something in the thing and completely made the page move. Hang on a sec. Oh, completely lost my thread there. Oh gosh. And I think this can influence professional as well as public attitudes. If someone from PET is typing in the chat, please don't, because he's making everything move. The other is that they need to fit us into a cis-het box. IVF access is the classic here. And yeah, I'm going to give up on that because it just keeps moving. Right, okay. And does anyone else want to come in? But I got most of Nick. Put me out of my misery.
I completely agree with Carole. I think attitudes have changed, and we could focus on that. But relating to this question, I think it has in part its origin in a more general view amongst part of the population that having children is a lifestyle issue, and that people put their own barriers in front of having those, and it's not something that requires sort of clinical management to treat as something that is an important part of life beyond being lifestyle. And I think that the LGBTQ community suffer clearly more from that attitude than the heterosexual community. But I think that is still a problem, and we're seeing it reflected in the withdrawal of the public sector from fertility treatment. That is in some ways mirroring that attitude, in my view.
Does anyone else want to come in on this one? Nope. Right. Okay, we shall move on. So someone asked, at a time of NHS huge financial cuts and the growing right-wing populism in government and the population which brings the anti-trans homophobia, what realistic chance do you think we have of getting fertility equality, especially if we can't pay for it privately? This person who's anonymous says, I'm not hopeful. I think I'm going to go to Jacob first on that one.
I think we're in really scary times, and I think that's unquestionable, especially for the LGBT community broadly, especially as trans people. And the far right rhetoric is terrifying. I don't think I would frame it in terms of how likely it is to happen, and instead I would frame it in terms of how important it is we keep pushing. If we frame it as, oh, it's not going to happen, so we may as well, we then fall back into well, let's just not try. But actually, now more than ever, we have to keep trying. We have to keep raising our voices. We have to find ways to be heard and keep moving, kind of pulling against that push to the right that we're experiencing. Yeah, I think, you know, things like what Nancy and Laura Rose are working on with the Fertility Justice Now campaign and things like that, you know, they've given an opportunity for everybody to go and do something towards us getting that equality. And so, you know, using the resources that are out there now more than ever, that's the time to do it, to try and get as much as we can and try and pull back to that point where our existence isn't political and even questioned.
Yeah. I think Nancy said that there's a very good chance of success in the short term for some areas of the Fertility Justice Now campaign. And I think that IVF access being the key, she says, it would be difficult for the Labour government to walk away or walk back on what the Conservative government promised in the Women's Health Strategy. The question is about how, and this comes to a point that Carole made, how we mandate this to ICBs who are the blockers here. And so I think that is the key point. And other areas will be harder with longer fights, like birth certification, partly because of backlash and partly because birth certification is a very complex area of law. And also that sort of records office is sort of quite impregnable in terms of getting change. And I don't know whether anyone else wants to come in on this one.
Yeah, I was just going to say, in terms of law reform, and obviously campaigning for more progressive laws is something I've been involved in for a very long time. And I think for a long time, it felt like we were moving in an entirely positive direction. And in the last few years, it does feel like there's a step back in attitudes and so on. I think social media doesn't help because it's so polarizing and everybody seems to think that they're entitled to an opinion, even if they don't know very much about something. But I completely agree with Jacob that we can't step back ourselves. We can't give up. We need to keep, you know, defending the things that are right. And I think in a slightly more kind of optimistic and positive frame, there are more of us all the time. You know, there are more LGBTQ families, they are more visible. And that gives us the opportunity to create good research about outcomes for children and outcomes for parents, which I really hope in the long term will help address a lot of the negativity, which really comes from a place of fear and lack of information. So I'm hoping it's a half a step back and then lots of steps forward to come in the future, and that we will kind of get back on track with that. And I think we have to hold that faith.
Great. I've got a question for Marcin next from Francesca Taylor, who says, I really enjoy your concept of spreadsheet fertility, Marcin. I see parallels with fertility social class in my work on online and unregulated sperm donation, where people who can't afford IUI and IVF, mostly LGBTQ+ and single women, are finding and conceiving with sperm donors online. I wonder what your thoughts are on this.
Yeah, thank you. Of course, online donation and meeting people this way is a tricky enterprise. It does happen, and it does also happen among friends who already know each other, and it can give some extent of freedom, especially from the economic pressures. However, we have seen many examples where it is just tricky. It might not work. So I would say that having some kind of support or structure, even if it's done informally, if it's done, you know, in all kinds of queer and creative ways, having some kind of a support structure could be helpful. You know, whether a charity or an organization where people can discuss those things and get some guidance, right? Unless they go to the clinic directly where this support structure is provided, right? Here there are economic barriers sometimes, so that's an option only for some. And perhaps in the world of surrogacy, it is a little bit easier because there are a few organizations, or mainly now 3 non-profit organizations that provide that support structure. So yeah, I will be curious actually to see, because it's the first study, I guess, one of the first studies at least that you're doing on online donation. So it'll be important to see the findings. And could I just say one more thing on the previous question? From the kind of international perspective, I think the very fact that these conversations are happening is already a success. That the conversations about the NHS and public funding for LGBTQ communities and fertility treatments are happening. The fact that fertility clinics, as has been said, have carved out that space for a long time, because in many countries in Europe, those conversations don't even exist. Right. So as Natalie said, I think there are positive things that we should just continue. And well, some examples, like the example that Carole gave about kind of a collaboration between or conversations between private clinics and local ICBs and the NHS could move things forward, or campaigning that has been discussed today. And perhaps we need quite a few projects of this kind. Thanks.
Thanks, Marcin. Nick, I was just wondering, and Carole, you might have views on this. Could you get many patients who come in having tried these informal arrangements that they've set up online and then coming to you for treatment, perhaps if they've not worked or when they've got a bit more cash to pay for it?
I suspect we do, and I suspect most of the time we don't know it, because it's the sort of thing that they will probably be quite reluctant to mention. But it is certainly, I think we have to acknowledge it as a growing phenomenon. We've got to be sympathetic to the reasons why it's happening, as Marcin alluded to. But we've also got to be very clear of the very, important risks that people are taking if they're not availing themselves of the regulatory safeties that the UK environment provides. And so we need to perhaps be more direct in asking people whether they have done that. So that we can help educate people about the pros and cons of it, so that they can make these decisions and hopefully spread that discussion more broadly.
Carole?
Yes, and just to add to the point about risk, in Sussex, the Integrated Care Board there have a policy which states quite clearly that to qualify for donor sperm treatment, same-sex female couples and single women have to have tried self-insemination or insemination in a clinic, self-insemination at home or insemination in a clinic for at least 6 cycles. So they're actively encouraging people who do not have the funds to perhaps go to a clinic and do private treatment to try this treatment at home. And that obviously opens the door to online buying of sperm, because that's the only way you can do it. So actually, the NHS is not, in my view, following the best practice by creating a policy that is encouraging this unsafe practice. And I'm part of the Fertility Access campaign, and one of the things that we are campaigning for is complete equality in terms of NHS funding for fertility care. So this sort of thing should not be happening or be encouraged.
Thanks, Carole. So I've got a bunch of questions now that I'm going to package together for Jacob. So one is a very practical question from Laura Mason. What is the title we should use when addressing patient letters? Is it MX instead of Miss, Mr, for example? What's the best way to tackle that? Then
sorry, I was going to just answer that one quickly. I would advise not using a title. If you know their name, use their name. Just simple as that.
Seems a very pragmatic approach. I like that. Then Bev Loftus asks whether you could recommend a book that would be good for transparent to use with their children about fertility treatment using their egg sperm or with donor eggs and sperm, whatever permutation you need.
So I would recommend, one that I use with my children is What Makes a Baby by Corey Silverberg. And it's a really great book because it doesn't gender anything. It talks about some people have bodies with sperm, some people have bodies with eggs, some people have bodies with a uterus. You need all 3 to make a baby. They may not be the same people. And it talks about who is excited for you to come into the world. And it's this very sweet story. So that's, What Makes a Baby by Corey Silverberg is very nice.
Great. And then someone says, thanks for your talk. I'd love to learn what you do I'd love to learn what to do when you get a person's pronouns wrong.
So this is what I talk about. I talk about individuals, groups, and oops when I talk about language. So if you're working from the premise that you've got something wrong or been corrected, what normally happens is you get sort of stuck in a sorry spin and you go, oh my God, I'm so sorry. I didn't mean to. I'm so sorry. And I don't see that, and you get anyone who's been wronged or done that will recognize that. I recognize it because it's happened to me and I've done it. And then what has to happen is the person who's been misgendered has to resolve that. So you go, this is Jacob, she is, oh, I'm so sorry, I didn't mean to. And I have to go, it's okay, I don't mind. And then the conversation can move on. I would like to propose an alternative, which is you get something wrong or you're corrected and you say a quick sorry or thank you. So if it's, this is Jacob, she, sorry, he is the birthing parent to his parent, you carry on, you make not a big deal out of it. Or if you go, this is Jacob, she, and I go, actually, my pronouns are he, him, or they, them, you go, thank you. And reframe that sorry as a thank you. Thank you for giving me that information. I now know more and can do better. You don't need to say all of that. You just go, oh, thank you. This is Jacob, he, and you move on. And so, yeah, that's my very quick how to fix an oops that I recommend for people. Reframe the sorry as a thank you, and any sorries you do make brief and move on.
Not go in a typical English sorry spiral when we say sorry for absolutely everything, even when we're not sorry. So yeah, great. That's really helpful. I hope the audience found that helpful too. Okay. So I think then there's a question for Carole and Nick from Ellen Conlon, who says, as service providers and from Marcin as a social scientist, what has the response been within your field and the impact on your service provision in light of the recent change in regulations about donors living with HIV? Am I correct in saying that this is only an available option in the case of known donors? Context: I'm currently researching EU laws written pre-U equals U evidence that governs and excludes people living with HIV from certain ART services in the EU. So quite interested in how Brexit may play a role in this opening up of possibilities in the UK, as you're no longer bound by EU directives about gamete storage. So it's quite a long and complex question. Have you two got that?
So I can kick off with that. So my background way back, 26 years ago, I started the sperm washing program for HIV positive people living with HIV in 1999, and at that time it wasn't even conceivable that people could be donors. And I think it's taken a long time since the U equals U campaign to get to the point where the law was changed last year. And in order for clinics to treat patients living with HIV who have an undetectable viral load, they have to apply to the HFEA for a variation in their license, the process we have just been through and got our license variation. And so we are now calling up our patients who have been sitting there waiting very patiently. We certainly know that they're experiencing great joy at now finally being become biological fathers, and so that side of things is very, very positive. As for those living in Europe, I think that to what extent that is going to be possible for them to have treatment in the UK, it's going to be a legal minefield, because many of them will be coming for surrogacy treatment, and I think that the law will probably make it more difficult unless they have British citizenship. So, but I'd let Natalie or the others answer that. But from the point of view of what's going on in the UK, it has been really transformation. For me, it's the last piece of the jigsaw puzzle in terms of giving people living with HIV the same chances of parenthood as those who who haven't been living with HIV.
Yes, the only thing I'd add is that it has been met with indeed widespread, enthusiasm and relief by clinics, because we were aware of this and encountered it every day, this injustice. And alongside, and the other one, of course, which I think merits mentioning, is the change in the requirements for screening of interpartners, donating to each other, treating them as couples, just in the same way you do as heterosexual couples. That's been a very profound change, and one which I think so far in our clinic has had more a day-to-day impact, because the other one is quite new. And like Carole's, we've just been able to arrange that change in license so that we can do this. But both of these, I think, are good examples, encouraging examples of things going the right way.
If I could add one thing to that, in my own research, I have met people living in the UK with HIV who couldn't do treatment in the UK at that time yet. That's why, and that was the reason why they went abroad, why they went overseas. Now they can. And so I agree with the previous comments on a very positive impact, I think, of this change. In the social science community, I would say the reception has also been very positive. There has been research such as, for instance, by Robert Pralat from Cambridge with HIV positive gay men in London who didn't even imagine that they could have children. Now, I think after this change and with the kind of awareness raising that is going on, this will be becoming possible.
You're on mute, Sarah.
Thanks. So I think there's a question that we have from a genetic counsellor. Let me just get that back up. Sorry, it's vanished now from my box. Well, actually, before I go to that one, I'm going to go to Natalie with one. How optimistic are we about surrogacy law reform? In particular, I note a pocket of people who consider surrogacy as a misogynistic act from men renting women's wombs. And I wonder if public opinion isn't on our side. And I know it's something you've been interested in, so we'll perhaps have Natalie and then Marcin on that one.
Yeah, and I think, I mean, I mentioned this earlier about social media and so on, but I think it's really interesting that when the Law Commission started their project, there was no real opposition to surrogacy in the UK at all. There were no groups, there were no kind of opponents on Twitter, now X. And that has something that's really changed, but it's really recent. And I think it reflects a tiny number of people and not attitudes in general. I think most kind of people on the street, if you talk to about surrogacy, are surprised that the law is the way it is, particularly around the surrogate being the legal mother and her spouse being the other parent and the biological parents not having recognition. So I don't think we should translate a couple of accounts on social media into a kind of change in public opinion. And I know there was a very good piece in By News last week about some of the misinformation out there. So I think we all just kind of need to stay calm when things are kind of said that are very extreme and just understand that that's the views of a very small minority.
Did anyone else want to come in on that? If not, I'll go to the question from the genetic counsellor, David Walker. He asks, is genetic screening offered or supported by fertility clinics in the UK for egg and sperm providers? We run into issues in the NHS where people at population risk want to be screened for a condition with no obvious family history of it. So I assume he thinks it's coming from that. So what are the screening, what sort of screening is done for donors? I don't know whether Carole or Nick wants to take that one.
Well, I think it's probably alluding this question to extended carrier screening, and that there is a very straight directive policy from the HFEA as to what genetic risks need to be screened for, and they're based on two things. One is their prevalence, and the other one is their severity. And I think it's a very good balance in general that's been found, so not to be too exclusive. But on the other hand, and ruling out or indeed informing potential recipients of any risk. One of the areas where we are seeing a growth of interest, particularly in donor sperm recipients, is extended carrier screening. And part of that is because it's provided by many of the overseas sperm banks, particularly in the US. And it generates knowledge, but it generates an awful lot of anxiety, often a level of misinformation. I did see one comment suggesting that there might be value in extending the screening to improve the chance of success. We have no evidence that it does that. It's all about reducing potentially a perceived risk of the babies being born with an autosomal recessive condition. But I think I would probably align with Carole's position, which as I understood it, was that we need to be cautious about extending carrier screening or extending screening beyond what we already have.
Great. I'm going to move on to another question because we've just got a few minutes left. And this is one perhaps for you, Natalie. Can any of the panelists comment on what is happening in the US with reproductive rights post the overturn of Roe versus Wade and the Trump administration, and how that might affect attitudes and services in the US?
I hope it won't. I mean, gosh, the US is such a strange place. I mean, I think there are kind of echoes of some of what we're seeing with Trump and the kind of move against diversity, equity, inclusion programs, you know, some of the attacks on the transgender community that obviously we don't want to see kind of filtering over here or kind of expanding. You know, there's small numbers of people that are promoting those sorts of things over here. But I think, you know, also in the rest of Europe, we're seeing kind of more right-wing, socially conservative kind of movements gathering pace as well. So I think the world is in, you know, a place of change at the moment. As I said earlier, I hope very much that, you know, it's a reaction to all the progress we've made and that we'll carry on continuing to make progress. But I think it's very early days in the Trump administration. Kind of we need to see what's going to happen. But I think it's really important that people stay calm, keep saying the right things, you know, be rational, make the arguments that are right, and kind of have faith that that will, you know, in the long run, play out as it should.